So thanks, everyone. Do your introductions. I'm going to hand it off to Dr. Bullard.
Thank you again. And yeah, I know this might be one that we've presented earlier before, and given that there's a lot of new faces, this might still be a topic that is helpful to talk a bit about. This is a topic that I don't think we see a lot, at least personally, I haven't seen a whole lot commonly done, and I think it might be helpful to know that is an option that exists. Next slide. So I always like to kind of think about a patient case, and this will not, for me, this would probably take nowhere near the full 30 minutes, but in this kind of situation, I'm thinking about a new patient who comes into our palliative care clinic to establish care. She's an elderly patient. She had a recent hospitalization. She had a lot of complications, including ischemic bowel. She had numerous GI surgical complications requiring numerous XLAPs and eventually developed sepsis during that hospitalization. Now, at that time, she actually got so sick that they actually discharged her home with hospice care because it was not anticipated that she was going to survive for very long given everything that was happening. But when she got discharged, they optimized her pain control, and eventually she started waking up more. She had implementation, and then when she got better, she and the patient's daughter chose to revoke hospice. They wanted aggressive care, and they were very open to palliative care support for ongoing symptom management. Next slide. So when she left hospice, in this situation, let's assume the patient was already increasing their opioids for pain related to the surgery that she had. At one point, she had gone up to MS Contin 60 milligrams TID and oxycodone 20 milligrams as needed. She was taking the oxycodone maybe 6 to 8 times a day, however, and still complaining of a lot of pain. Now, the daughter who was acting as her caregiver mentioned that she looked somnolent, but the patient kept asking for more and more of the medication. Eventually telling her that she hurts without it. When she was told that she couldn't have it at the time because she wasn't prescribed it yet or didn't have enough, she became very agitated. And the daughter, of course, became very concerned by this. Now, at one point prior to her establishment with us, she had even been seen in the ED for altered mental status. At that time, very somnolent. She had respiratory support. She needed Narcan. She was frustrated when she was in the hospital at that time, saying that she just hurt all the time and they wouldn't give her medications. Next slide. Now, if this sounds kind of like a test question setup, it kind of feels that way. This is a patient who we're seeing a lot of signs of uncontrolled pain, and we're thinking, what options do we have that exist? And probably the bells are buzzing in your head as we speak, thinking that this might be a good patient to think about OAT. Next slide. Now, I think some shared knowledge going into this discussion. I think we all agree pain is complicated. That's kind of the reason we're here. We know it's complicated. We know there's different types of pain. There could be acute pain, there could be chronic pain, and it is possible to have both uncontrolled pain and opioid use disorder at the exact same time. And when these things come together, it's important for us to remember that there are a lot of stigmatizing terms that we need to avoid. Knowing that there's a big difference between addiction and dependence, we know they're not the same. We know that patients may require a lot of medications for optimal symptom control and stabilization. That doesn't necessarily mean they're addicted to the medicine. Avoiding that stigmatizing language can be a big asset. And as far as thinking about options, there are options that we know can treat both together. Two options that I think about would be buprenorphine, or commonly Suboxone, or methadone. Next slide. Now, as far as, like I mentioned, these medicines work very differently. One of them is a full agonist, one of them is a partial agonist. And I think there's a range where both medications could be helpful in this specific patient. For this case, let's, for sake of argument, say we choose buprenorphine. Next slide. Now, of course, we picked that as our medication of choice. She's currently still on the morphine and the oxycodone, however, and we're worried about inducing withdrawal side effects in this patient if we were to initiate it too fast. So because we want to make sure she has close observation, we say, hey, let's bring her to the hospital and we can do induction under guidance. How do we initiate the medicine? Next slide. So we're probably all used to seeing these type of equal analgesic tables, these doses that kind of give us an equivalency to know how we can convert from one medication to another. This is just one that I had found from another source. I have my own that I use and I keep it in my pocket, but not often are we going to see medicines like buprenorphine on those because it's not a standard type of a dose curve. Next line. where a lot of medications that we see are going to be full agonist effect and kind of have an increasing effect as we increase the dose. With buprenorphine, it has a partial agonist effect, and there's a kind of a plateau effect that happens when we hit a certain point. Next slide. Now, knowing all that, there are a couple of ways we can do inductions, and these might be things we're familiar with, but I think a reminder of these things can be helpful. Two of the common ones that we see, there's the traditional method, and then there's kind of a low dose or micro induction. Now, with the low dose method, we're thinking about how can we avoid precipitating withdrawal. And this is done by using a very small and gradually increasing doses of the medication. And the benefit of it is we get to avoid the need to just stop full agonist altogether. So a patient can stay on their as-needed medication like oxycodone for breakthrough pain, and that stays in the system, and we slowly titrate up on a very, very low dose across day by day until we hit kind of a steady state. I won't go into the full details of that adjustment here, of course, but typically we're starting in the range of like 0.25 milligrams of buprenorphine to maybe at 1 milligram a day at a time, and each day going up by a little bit. Maybe start at 0.5 once a day, and then 0.5 twice a day, then maybe 1 milligram twice a day, and so on and so forth until we kind of hit our goal range, which normally it gets to maybe 8 milligrams twice a day or so, sometimes lower if someone has more of an acute pain. But most of the time we're doing this for our patients who do have OUD, or opioid use disorder. Now, for the traditional method, the downsides of it is that you have to wait and discontinue the agonist so you can start those signs of withdrawal. And that normally occurs 12 to 36 hours when you're off medication, about 12 hours or so if you're doing more short acting and not on super high dosages. If you're on a long acting and higher doses, maybe a day or so. And if you're on methadone, it could be as high as 36 hours. And then when you start buprenorphine, you want to wait till you start seeing that mild to moderate withdrawal. Here you start at a bit of a higher dose, and you can do it kind of as an as-needed basis with a maximum amount. Typically, I like to think about maybe starting 2 milligrams every 2 hours as needed with no more than 8 milligrams on day 1. And then you kind of slowly increase the requirement. Maybe on day 2, go up no more than 12 milligrams in a day that you schedule, or you start with 12 milligrams that you schedule either once a day or split in a split dosing by maybe 4 times or twice a day. And then using as needed 2 to 4 with a maximum of 16. And eventually you titrate to that same kind of goal range. Next slide. So yeah, we decide this is what we're going to try. However, prior to initiation of this option, let's say the patient now gets admitted to the hospital again, this time with new abdominal concerns. Patients found to have a GI abscess, they need drainage, they undergo surgery again. They're told they have a hostile abdomen, and while they're doing the surgery, they start having more issues with nutrition. Eventually, because of nausea, because of vomiting, because of poor toleration of medication by mouth, she's told to be NPO. We initially think about trying to sublingual, but we notice that she doesn't have a lot of secretions, and she tends to spit the medicine out because she doesn't like the taste, and that makes her very non-adherent to it, or she just doesn't ever dissolve it, and it's there for quite a while. So now that she's in the hospital, before we were able to admit her for this induction, we were consulted to help with her pain and management. So, of course, being the astute physicians we are, we know there is the option of IV buprenorphine. But how do we go about an induction on IV buprenorphine? Next slide. And that kind of brings us to the article today. And I knowing that we've reviewed this before, I think it's cool to kind of go through the details and kind of see what new things we have on. And for those who haven't seen it before, this is a case where they actually used IV buprenorphine for induction at kind of a low dose protocol. That way they can treat patients who have both concurrent pain and opioid use disorder. And it was one of the, I wouldn't say larger, but it is one of the few studies we have out there that goes into this. Next slide. So going into the article itself, they of course introduce a lot of things that we know. Opioid overdoses are really the majority of medication overdoses in the US. We know that over the last several years have been worsening death rates over time, and we know that opioid agonist therapy, or OAT, has been proven to be effective at reducing mortality of these patients. Now, what we recognize looking into it is that these are things we often see initiated as an outpatient, but inpatient and hospitalization is an often missed opportunity that we could potentially start these patients on medication. Next slide. So this goes back to the Center for the National Center for Health Statistics, and this actually shows some of those drug-involved overdose deaths across time. And you can see that it really does steeply increase Here in 2021, it's gone up. It looks like every year it's going up more and more. I think it was a 15% increase from 2020 in this chart, and maybe about a 30% increase from 2019. And we see that when it comes to which medications are the most commonly being seen in these overdose cases, it is synthetic opioids, other than methadone. Next slide. So what barriers are there to us when we try to initiate buprenorphine use, and talking about IV specifically? Now, traditionally, we really can't start it until there is that mild-to-moderate withdrawal by the traditional method. And the problem with that is that when we try to wait for opioid withdrawal, patients hurt. And that can sometimes limit both the patient willingness to start the medication or initiate this transition, and providers' comfort with administration, because we don't like to see our patients hurt. No one does. Also, there's always a risk that if we start too early, we might precipitate withdrawal. And that also might lead to patients not being willing to try it in the future, or providers not being willing to prescribe it. Now, that's the challenge when we know that pain is so common in our hospitalized patients. And some studies have shown that up to 65% of patients have pain within 24 hours of the hospital stay, and over half of patients hospitalized, or almost half, and this is non-surgical patients, are treated with opioids during their hospitalized stay, which is a very surprising statistic to me. Now, low dose induction is an option, and I think is a good option. There's good studies on it, but sometimes there's protocols preventing alteration of medications. Next slide. In this particular study, in their hospital system, they don't allow them to alter medicines, because when we have a small strip, you might think about cutting that medication to try to reduce the dose. That way you can do that low dose induction. But when that's not allowed, IV buprenorphine can be used as an alternative. There's been other case series and studies that have shown that it can be safe and effectively used for patients who have acute pain, and that's where it often is used. But there's not a lot of great studies about low dose induction. Now, the benefit of doing a low dose is that it can limit the need to wait for precipitated opioid withdrawal, or patients starting to show those signs of withdrawal. Now, thinking about the dosages, this is where there's some data on it, but it's still not quite spot on what the actual bioavailability is. Some studies are around 30 to 50%. So you would imagine that if you're doing maybe a 1 milligram induction, yeah. So I see we have a comment about the actual MME of it and how much does it kind of approximate to. And that's where there are some things that kind of calculate it, but I don't think there's anyone that's super great on that actual number. And if there's someone who has more data on it, I'd love to talk about it during our discussion at the end. But what it seems is that thinking about if your goal was doing a low dose induction, say you were planning to start on 1 milligram of sublingual, you can assume maybe 30 to 50% of that you can use by IV as the approximate dose. And that's kind of the logic they went behind in this study. They have similar pharmacokinetics between IV and sublingual. And normally, while it's used for acute pain, this was a good study showing how you can use it for treatment of agonist therapy. Next slide. So the big methods of the study, it was a retrospective case series where they used low-dose IV induction in hospitalized patients. For inclusion, it was any patient in a 10-month period who had received IV buprenorphine for a low-dose induction, and they had to have also received a full-dose agonist within 24 hours of initiation. Now, people that were excluded from the study were those who received IV buprenorphine for other causes, such as acute pain, if it was a traditional induction method, not using the low-dose induction, so on and so forth. Or if they were using methadone as their full agonist and it was only being used for their opioid use disorder and not for acute pain. Next slide. Now, the primary outcome measured by the study was the patient's ability to successfully transition to the sublingual formulation. And that's in the hospital stay itself. Secondary outcomes they also checked were patient-reported pain scores that were aggregated, nursing documented CAL scores, and hospital discharge with a prescription for sublingual buprenorphine at time of discharge. Now, they use two different low-dose induction methods, not to be used with the low-dose versus traditional. They use a standard low-dose and a slower low-dose. Next slide. So this goes into some of the way they were determining how they could calculate how to initiate. These are several studies that have been used to show both sublingual low-dose induction, as well as published studies that show IV induction. And while these are all different ways to dose it, there is some similarity between them where you kind of start at a lower dose and you slowly increase over time. Next slide. Now for them, they chose two different regimens, which I have included here, and I can always come back to this later on if we need to during discussion. For the standard method, they started with an IV dose of 0.15 milligram, which of course approximates to maybe about a little over a quarter or so of a quarter to a half of the actual sublingual 1 milligram dose itself. And they do that every 6 hours as needed. Now, day 2, they increased that by double. And on day 3 to day 4, they tried to transition over to the sublingual formulation when able. Next slide. Now, on the slow regimen, it's very similar, except for the doses instead of every 6 hours or every 12 hours on the first day 1 and day 2. And then we once again try to transition on day 3 to 4. Next slide. Now, what were the results from this study? Now, in the study itself, the total number of patients that we saw, there were 60 patients in that 10-month period who did receive IV buprenorphine. Of those, 49 of them received for low-dose induction. And then of the remaining 49, only 33 of them had received full agonist within 24 hours. Still a pretty good size, given that this is not a common thing that we see done. Now, of the characteristics, when we were looking at the patients themselves, there was a predominantly male and a predominantly African-American population. About 20 of those 33 were male and 24 were African-American. All of them had a UDS obtained, or many of them had a UDS obtained at time of admission. I think about 22 of them. And they kind of calculated the average MME, and it ranged from about 15 to 16 to 24 hours prior to induction, with an average of about 30. Majority of them actually completed induction and were discharged with a prescription as well, 30 of the 33, which is about 90%. Next slide. These are the breakdowns of the actual characteristics themselves. I'll leave it up for just a little bit if anyone wants to kind of review. The UDS I included here as well kind of surprised me. I guess everybody's different depending on where you're located. In my population, I often will see a very common use of marijuana or cannabis on the UDS, and but it's just something I kind of appreciated. Next slide. And as far as medications, you can see all the patients required 24-hour opioids prior to a macro induction. The MMEs, you can see they're around 30.8 with a range of 15 to 60. And then majority of them were around day 4 of their admission when they started the induction. You can kind of see which ones were discharged with of the 30 that were discharged. Is that buprenorphine 1 to 3? It's close to that. I saw the question there. So 1 to 3, 30 to 50% or so is what I was seeing there. And that's kind of the conversion that I've used as well. Now, as far as discharging, someone went home with buprenorphine only, some went home with scheduled, and some went home with as-needed opioids for breakthrough. Next slide. So what were the overall results and discussion that they commented on during the at the end of the study? Now, of the study itself, there were 3 instances of treatment failure. And one of those was a self-directed discharge. One of those was actually not really a treatment failure in my mind. It sounds more like the patient was on methadone before. They couldn't start methadone because of a prolonged QTC, and when it improved, they actually were able to resume their methadone. So I would not really count that as treatment failure in my mind, but they included it here. And one of the patients stopped because they had worsening acute on chronic. Other things they saw in the results was with the aggregate pain scores, which were patient reported, and CAL score, there was a fairly wide variance of, but the trend overall was that there was improvement on both scores, especially near the end, being lower. Next slide. Now, this comes from the article itself again. This is the reasons why some patients actually had to adjust their doses initially. Of the patients included, 27 in the standard and 6 in the slow regimen. 2 of them had opioid withdrawal induced, and they had to kind of adjust the regimen from that current protocol that I showed. 3 of the patients had uncontrolled pain, and they had to change the regimen from that. 2 of them, it was patient safety. 1 of them needed to be intubated. 1 of them couldn't swallow anymore. 1 of them was too somnolent to stay on the trial or stay on the current dose, and they needed to adjust it. There was that self-directed discharge, and then there was the medication ordering error because there was some confusion with how non-universal these things were. Next slide. Now, the final table that I show here is actually going to be the reported CALs and pain scores. Can you go to the next slide? I think it went out of order there. I think I'm missing one. There it is. Let's do this one first. So this one here was day 0, day 1, and day 2, where they had patient-reported pain scores, which you can see there in the CAL score. both on the slow and the standard regimen. Now, you can see there on the CAL score for the standard, I guess for the total was 2.6 at the start and 4.4 for the pain score. Next slide. And then the aggregate score was 1.4, it was 1.6 at the end for the CAL score and 3.5 for the total at the end for the pain score. Now, next slide. Now, some limitations of the study is there was some data reporting imprecision, and especially in the first 2 days. Because on day 0 and day 1, it wasn't truly 24 hours. Because day 0 was more than 24 because it started whenever they started. They were started on the 24-hour agonist and then moved forward until they first initiated. And then the day 1 was not a full 24 hours because it was right when they started until midnight. And then afterwards, it was midnight to midnight. There was less data for the CALs and pain score reported later in the hospital stay, which might lead to some possible skewing. However, the author argues that if the skewing happened, it was likely that the scores were higher than should have been, or skewed to a higher CALs or worse, or a higher or worse pain score, because the patients who were having more pain and more symptoms were the ones that would have been reported more frequently by nursing. Now, there wasn't a perfect standardized regimen, and that's why there was some ordering errors that we mentioned before. And now, during the time when we were withdrawal, there wasn't any data on the adjuncts that were used associated with that. Next slide. And then their final conclusion of from the article itself was that IV buprenorphine can be used as an option for low-dose induction in hospitalized patients. It has a level of precision to it. It's affordable. I put a question mark by that because I couldn't find any data on the cost, and I'd love to hear everyone else's thoughts in the group if they do know it. And it's shown to be safe. It's also easier to create a protocol for it since you don't have to cut it like you do with the sublingual if you're using very, very low dose or micro dose. Low dose induction can be started immediately. You don't have to wait for withdrawal to be precipitated. And that prevents delay of initiation. And that might help with hospitalized patients because there's always that pressure to get people out of the hospital and reduce length of stay. And patients can receive full agonists at the same time. And that's another benefit of this, because if they're having breakthrough pain, they might feel more comfortable doing that. Which increases patient and provider willingness to initiate buprenorphine. Next slide. So that was the article itself. Now I'm going to I wanted to spend some time and open up to the floor for other people about questions. I know I'm probably hitting the 30-minute mark, so let's see what people have. So thoughts, comments, questions. Has anyone used this before?
Thanks, Lee. We've got a lot of discussion happening in the chat with some pharmacists, and Dr. Dunn from University of Louisville, I think has started using this more. And thanks for pairing this with like a patient case, taking it from that perspective, and then just mainly pointing out feasibility. This is feasible to happen in the hospital, did not worsen patients' outcomes, and was a way to start